So I just heard from the operating room, and they are on time for us to go live at 11.
Okay, so welcome to my world. Patient care always trumps giving the lecture, so I apologize for delaying this. So let me give you a little introduction to what you're going to see here. We just opened a new tower called the Walter Tower, and part of education is built into this. All the operating rooms have remote broadcast capability. That's what we're going to leverage today. One of the partnerships you see up here is Storts, and they're responsible for our audio-visual integration. So what we're going to do is go into one of the operating rooms at Methodist. Each year we've kind of shown heart surgery. It's a little bit of a variant today. The surgeon is Dr. Randy Wolf, and he has developed something called the Wolf Mini Maze. Can you bring up the volume, please?
Dr. Lumpson?
Yeah, hey Randy, how are you?
Alan, how's the voice? Is it okay?
Yeah, no, we got you. We can hear you pretty well. We just showed that video of which emphasizes the importance of AFib. Probably 10% of the people sitting in this audience have atrial fibrillation. And we're going to tell you a little bit. Yeah, I can hear you. I'm going to show a few slides first, Randy. Go ahead.
You gave it all away. You've already shown it.
Yeah, we already shown it. Sorry. Yeah, I just stole your thunder a little bit. Let me show a couple of slides, and then we'll come to you, Randy, and you can show us what you're doing, okay?
Sure, we're ready.
Okay, so his name is Randy Wolf. It's an operation that he developed, and he's been working with us really for the past couple of years. And we're going to tell you a little bit about atrial fibrillation, and this was one of his patients. And the reason that's important is because if you're a pilot, and I met another one of his patients who walks in for his annual physical, these pilots basically handle stress very well, except when they come for their annual physical. Because you walk in there and you are diagnosed with atrial fibrillation, you are done. You cannot fly again. And so that was really one of the pilots who'd actually showed you that getting back into what's called sinus rhythm, we'll show you what that is in a minute, is really very important and affects their life enormously.
The heart is a muscle that contracts in rhythmic sequence for the duration of our lifetime. Each beat is stimulated by an electrical signal that is generated by the heart's conduction system. A normal heart beats 60 to 100 times per minute. Sometimes a problem with the conduction system causes the heart to beat too fast, too slow, or to have an erratic or irregular beat. A test, called an electrocardiogram or EKG, can measure and record the heart's electrical activity. In a normal heartbeat, the heart's signal follows a specific pathway through the heart. The signal begins in the sinoatrial node, or SA node, located in the right atrium. The SA node triggers the atria to contract, pushing blood into the ventricles. The electrical signal then travels through the atrioventricular node, or AV node, and into the ventricles. This signal now causes the ventricles to contract, pumping blood to the lungs and body. Atrial fibrillation is a type of arrhythmia or abnormal heartbeat that is caused by erratic electrical signals originating from the atria. During this rhythm disturbance, the normal coordinated contractions between the atria and ventricles become compromised, interfering with the heart's ability to efficiently deliver blood to the body.
In people who experience atrial fibrillation, many rapid electrical impulses originating from different areas of the heart are sent to the atria. These impulses cause a very fast and chaotic rhythm. Because of this rhythm, the contractions of the atria become erratic. As a result, the irregular contractions of the atria do not properly fill the ventricles with blood, causing the ventricular contractions to also become erratic.
The heart rate may increase to 100 to 175 beats per minute or more. Atrial fibrillation can cause fainting, weakness, and may lead to blood clots and other complications. The condition can be treated with medication or with surgery. In some patients, a pacemaker may be inserted in order to regulate heart rhythm.
Okay, so Randy, we're about to come to you, but let me just say that the issues that you're going to see him dealing with, there are many different ways of treating atrial fibrillation. One is with medications to regularize your heart rate. The other one was ablation, which is delivered by an electrophysiologist. We think of these as the electrical engineers of the heart. They're trying to work on those conduction pathways, and they try to destroy them from the inside of the heart. And another way to do this is from the outside of the heart, and that's really what you're going to see Dr. Wolf doing today. So Randy, we're ready for you.
All right. Good morning, Alan. First of all, thank you and Pumps and Pipes for allowing us to present today. As you said, we're in the Walter Tower at Houston Methodist and DeBakey Heart and Vascular Center, arguably the nicest operating rooms in the world today, thanks to Dr. Lumsden and his team.
So let me just tell the audience what they're looking at here, Randy. Okay, first of all, they're looking at you. He's wearing a headlight, which is one of those things, and he's wearing magnifying loops. So we wear magnifying glasses, and that headlight is that cool-looking thing goes over the top of his head. We see the nursing staff in the background, and the bottom left is he's monitoring signals from inside the head on what's called transcranial Doppler. We take an ultrasound, we fire it through bone, calcium, to look at blood flow inside the head, to make sure we're not firing any particles up there while he's doing the operation. And then the bottom, and he'll magnify that a little bit, is a view of inside the chest. This is done through making small incisions in both sides of the chest. Next to that is the EKG, which is going to be very important to him because he's going to test whether the ablation that he does interrupts those electrical pathways. So go ahead, Randy.
Well, this is a 71-year-old male, and interestingly, he's in the oil and gas business here in Houston.
There you go.
And,
Couldn't have done it better.
We asked him if he would mind us showing a little bit of his video, and he's, as a typical engineer, his only question was, "What's my royalty?" And I told him, and I told him, well, he said, "I bet my royalty is the same as yours." And I said, "You're correct." Yeah. So he's had an ablation before. You mentioned catheter ablation. He had a catheter ablation. It was not successful, which is not unusual. He's been plagued by very symptomatic atrial fibrillation. He's incapacitated when he goes out of rhythm. He was in rhythm this morning, but then he went out of rhythm just a few minutes ago. When we first came on screen, he was out of rhythm. He also has high blood pressure. He's had a heart cath. He has no coronary issues. He came to the operating room a couple hours ago. Dr. Scheinbaum, who's done these procedures with me for several years, is our anesthesiologist. It's a general anesthetic, and then the patient is turned on their side. Our goal here, Alan, is to do a heart surgery without putting our hands inside the chest. That's the goal, and that allows us to make smaller incisions. Many years ago, now almost 20 years ago, catheter ablation got started, but for the surgeons, there wasn't really a very good way to isolate the pulmonary veins from the AFib. And this is really an engineering story. Mike Kubin, who was a friend of mine, electrical engineer, asked me if he thought we could use bipolar radiofrequency clamps to isolate the pulmonary veins. And I said yes, and we started the work in my lab probably 20 years ago. And you'll see what we developed, which is used now commercially around the world. So this is really an engineering story on both sides. The development of the devices and all the way to the patient, an engineer who has AFib.
So let me just interrupt
Any
and say
questions?
that what's generally, he keeps mentioning the pulmonary veins. The pulmonary veins bring blood back into the heart once it's been oxygenated. But it's thought that in most patients with atrial fibrillation, not all, there's an abnormal electrical stimulation pathway that begins in the pulmonary vein, and that's what creates this rapid, unsynchronized beating of the atrial right and left atrium themselves. And the concept is if you ablate all of the electrical wires, and you're going to hear some interesting concepts in electrical wiring in the heart later this afternoon, then that may help the patient get back into what's called sinus rhythm. So go ahead, Randy.
I'm in a group of researchers who believe that these abnormal electrical stimuli in the heart are the cause of an imbalance of the autonomic nervous system. So one of the advantages of what we do is this clamp, you'll see, goes around the outside of the heart. So all those little autonomic nerves, we will isolate automatically, which cannot be done through the catheter ablation. So these are the nerves that make your hands sweat when you're on top of a tall building and you look over the edge. These are the nerves that make your heart go fast when you're watching a scary movie. Why should your heart go fast? You're sitting in a chair. These are the autonomic nerves, and I believe that an imbalance of these nerves is what stimulates the heart into atrial fibrillation.
Okay. We can't wait to see what you're
I'll
going
bring
to
it over to all right. So we'll start outside here. We'll clean off the scope.
Okay, so what
We
you're
have
looking
a-
at, let me just talk a little bit so they know what we're looking at. So you're looking at a scope. A scope is like a 10 millimeter diameter thing with fiber optics on the inside of it. That's what he's going to stick inside the chest, and then we're going to see that signal. And so there are ports. That's called a port through the chest, and there's a small incision, and the small incision is to get a clip in that he can clip the atrial appendage with. And we'll talk a little bit more about that. So now you're seeing the heart beating.
So we have opened the heart sac. All mammals, whether you're a squirrel or a human or a raccoon, have a heart sac. And we've opened that heart sac, Alan, from here to here. Mm-hmm. So we can see the outside of the heart. So the heart sac is open. This is the left atrial appendage, this structure right here. It looks like an appendix. In 97% of cases, if someone has a stroke and AFib, it's because they had a blood clot right here. So an important part of the procedure we're going to do is to close this appendage. That will isolate the appendage from the rest of the heart, isolate that cul-de-sac, and this engineer will no longer have to take a blood thinner. A lot of the patients that come to see us say, I have AFib, I hate taking a blood thinner, or I can't take a blood thinner. And by closing this appendage, they don't have to take a blood thinner anymore, and their risk of stroke goes down 97%. For those of you that have AFib and take a blood thinner, your risk of stroke is still 40%. Blood thinners decrease the risk of AFib stroke by 60%. Closing this off, 97%, and you don't have to take blood thinners.
We can hear you at the moment. We just lost the video signal for a minute, Randy. Hopefully we're getting it back. There we go. Well, that's a good-looking picture of the guys organizing. Hope that's not inside the chest that you're operating on.
Another vein here. This is the left lung.
All right, now we got you.
And these are a few sutures. What's that?
Yeah, we're back. We're
What?
back. We lost the video signal. So can you just show us the pulmonary veins again?
Yes, sir. This is the superior pulmonary vein. This is the inferior pulmonary vein coming back from the lung that is right here. So this brings the blood back from the lung to the left atrium. This is oxygenated blood. The pulmonary artery is up here. And this is the ligament of Marshall, which we divided, which is chock full of those autonomic fibers that I believe and other people believe causes the AFib. We did the right side first, and if we look down here, Frank may be able to take us down here. You can see the ablation from the other side. Right there. Right there. That's the ablation on the right side, which we've already completed. I don't know if you could catch that, Alan.
So what he's talking about, in order to do
Catch that?
both sides, they have to make one of the challenging things is you
Yeah.
have to position the patient. You have to roll them left side up to get the left side, right side up. So it's a staged operation, done at the same setting, but it's basically
Right
done in
there.
two phases. Yeah.
There's our ablation from
Yeah,
the
we see
right
it.
side. Look from the left.
Ablation
Okay,
means
come back
burn, basically. Those are burn lines on the outside.
So now the next step is we have to get around the back of the heart. But first we're going to check the signals in the vein. Then after we use the clamp, hopefully the signals will be gone.
So what he's going to do is stimulate the nerves on the pulmonary vein and see and detect that on the atrium. So stimulate it, detect it, stimulate it, detect it. Then when he does the ablation, stimulate it, no detection. So it means that the nerves are ablated. You can't really see these nerves, they're kind of microscopic.
I mentioned that we started with Mike Hooven, an engineer, electrical engineer, and ultimately he started a company called AtriCure, and that's what you see here, AtriCure Company. These devices now are sold all around the world. These are one of the things that are exported from the U.S., not imported. And surgeons all around the world now use this device. It's the #1 device in the world, and it all started in a lab in Ohio. So this is the superior pulmonary vein. Jody Sweetwater is our representative from AtriCure, and she's running the machine. We got signals there, right? So we have signals from the heart going into the vein, which is normal. Here's the inferior pulmonary vein. And here's the bifurcation. So we have signals, and after we use the clamp, we hope to have all those signals disappear. Could you see the signals? Was it hooked up so you can see them?
Yes. So for the marketing students, these surgical companies pretty smart. They stick the name of the company on the end of the instrument so that anytime we broadcast, so lesson #1 is.
So the heart is not in rhythm right now, Alan.
Yeah.
If you look at the appendage, you can see it's going about 300 beats per minute. But the ventricle, which is down here, is going about 60 to 70 beats a minute.
So essentially the atrium is sitting there going like this. It should be going like that. The ventricle is beating like this. And so what happens is you get ineffectual priming of the left ventricular pump. And perhaps more importantly is you get the stasis that he's talking about in the atrial appendage. And when there's stasis, blood clots form. And then what happens is you suddenly turn the patient back into sinus rhythm, and it goes, and it squeezes any blood clot out, and it goes through the left side of the heart, and that's probably the most common cause of stroke that we can get. So you see how rapidly it's beating there. That's not good.
That was positive, wasn't it? Didn't it stop? Now watch this, Alan. The red line is the blood pressure.
Yep.
You see that on the screen?
No, we don't have that.
It's the third line down.
Yeah, we don't have it. There you go. Now we got it. Okay. So the 100 over 61 is the blood pressure. Yep.
I'm going to take this can and deliver a tiny bit of electricity, not even enough that you can feel it on your finger, right over where I think one of the nerves is. And then Jody's going to turn on the machine and stimulate, and watch if this slows down the heart.
Yeah, pretty impressive.
See that?
Yep. So he's controlling the heart rate by the stimuli that he's applying to those nerves in the pulmonary artery, pulmonary vein, I should say.
Try it again, Jody, right there. And we're on again. See the heart slowing down?
Yep.
That means he's got positive nerves, and I think that's what puts him out of rhythm. You can burn all day on the inside of the heart, you'll never get those nerves.
Okay.
Now he's trying to go into rhythm. The heart is going into rhythm. Now see the atrium's not bouncing around so much.
Yep.
Now we're in a love dub. That's a love dub.
That's what it should look like.
That's normal rhythm now. And that happened just from stimulating those ganglionic plexi, those autonomic nerves.
So it's the
So
nerves.
it's hard to tell me that that's not important for arrhythmia. But these nerves are on the outside of the heart. You can't get to them from the inside. Now pull the scope out, Frank. This is a device that we developed, and this, what's going here? This
That's
is
the
a
heart
device
beating
that,
at the top and bottom of that
developed
decision.
that
That's
acts
between
like
the
my
ribs.
finger. Because we're not putting our hand inside the chest, we need some way to get around the back of the heart. So this is an articulating device, and it has a little bright light on the tip. The light is made so it will transilluminate fat, but it does not transilluminate arteries and veins very well. So it's like the Bible says, let there be light. If you see the light, it's safe. If you don't, it's not. And we're going to put that in here through this port. Then Frank's going to come back in. We'll go inside the chest again. You see how much more comfortable the heart is now? It's not bouncing all over the place. That's because he's in rhythm right now. That's our light. We'll put this around the back of the heart.
So this is where the skill's involved. You don't want a hole in the backside of this.
I'll hold that down. And
Holes in big blood vessels where we can see it and we can fix it. Holes on the backside of a big blood vessel, challenging. It's the reason that this was developed with that the light coming out of the end. So by turning the handle, you can make different sort of curves, and it's blunt, and the transillumination shows you whether or not you're likely to be coming through something you don't want to be coming through.
the lungs coming up, boy. Now, starting to see my light right there.
Yep, looks good. So now he's got this curved clamp round behind the pulmonary veins.
Come back a little bit. Come back a little bit more.
And again, what we were saying was the physician identified the challenge, and the engineers solved this problem by building these devices. It's really important that we work closely together. So what he's doing there is just pulling a tube through that can be used as a guide.
What's that?
Oh, I'm just talking about what that red tube is. It's going to be a guide to bring in your ablation clamp.
So now we have a red rubber around the back of the heart that's connected to the bottom jaw of the clamp. And that'll help us slide the clamp around in a little bit safer fashion. The first couple cases like this, I did without this sort of device. I hadn't come up with the idea yet. And I realized that we had to have something that was safe that could come around the back of the heart. So coming up with this lighted dissector was a big deal and allows us to see. Now we're all the way around, come in a little bit to the top of this. Now you can see the bottom jaw is all the way around the back of the heart, right there.
So that's the back jaw. And the front jaw you can see, and that allows them to clamp down across the pulmonary veins. There you go. And that's them clamping across the junction of the pulmonary veins and the left
Bring
atrium.
the pedal up onto. So now we've just clamped inside the veins. We're on the heart. And now we can deliver bipolar radiofrequency energy. And you should be able to see it on the AtriCure screen.
Yeah, we don't have the AtriCure screen up. You can get rid of the TCD. It's not really telling us anything.
What takes the electrophysiologist about 2 hours to make a ton of little dots, and hopefully they all connect, we can do here in about 7 seconds. We just made the whole line all the way through the heart done. We'll do it a few more times before we test again. Sponge stick.
So one of the engineering challenges and the debates, and I say that in its broadest sense, it takes place between the electrophysiologists and the surgeons, is when you do this with a catheter, you ablate, you burn the inside of the heart. And the problem with that is you can get clots form on the burn lines. And the TCD, which is the bottom left-hand corner, we're looking for particles going on up into your head from doing this. And you get almost none when you do it from a surgical standpoint because the ablation lines are from the outside in rather than from the inside out. In fact, we've almost abandoned doing this because it's just a waste of time. You just don't see small particles going on up into the brain. And when you do it with a catheter, it's one of the highest instances that we've ever documented, actually.
So the machine tells us when the impedance goes to infinity, the electrical engineers in the room, when the impedance goes to infinity, we don't get any more conductance and we turn the clamp on. So we're measuring impedance many times a second. We're getting feedback, unlike, again, with the EP devices, they just burn for a certain amount of time and a certain amount of watts. But we're looking at an impedance screen, really conductance, which we can see on the back here, but I'm not sure you can see that. We're looking at, let me pull this down a second.
So you done with it?
No, we're looking, that's that bottom screen we're looking at that gives us our impedance right there. And that's how we know very carefully how much we've burned. So we've done it a few times now. Let's test again the veins and see if there's any signal in these veins. There was a signal before, but now we've made this line, and there's the superior vein. Jody says that's quiet, no more signals in that vein. Here's the inferior vein.
So what does that mean, Randy?
We're going to burn a couple of times. What it means is that now the signal from the heart can no longer get into the veins because of this burn we've made.
Are you going to burn it again?
Do a little bit more here. So now I'm applying energy. This is on the atrium proper. Don't want to see the.
So although you can't see anything, there's energy being applied between those two blades of that clamp, and that's what's causing the ablation into the wall of the atrium.
Yeah, so I open the clamp. We can reposition it just a bit. Close it again. And then I have a foot pedal. I'm delivering energy now. The energy is just, the other thing about this, Alan, it's very safe because the electrical energy is only going from one side of the clamp to the other. As you know, with normal monopolar radio frequency, we put a grounding pad on the patient, which is done with catheter ablation. The energy, the electrical energy, takes the path of least resistance. Well, sometimes that can be somewhere where you don't want it to go. And so this is very safe. The energy only goes from this side of the clamp to the bottom side of the clamp. Here's the intrapulmonary vein, Jody, right there. A little bit of something there. Let's look at the top one again. That looks pretty good. All right, we're going to burn a couple more times until we don't see any signal in there. So we'll put this down here.
Can you burn it too much?
No, you can't. We worked a lot in the lab on this device to make it absolutely safe. The engineers did a fantastic job. We continue to work on new projects. We got a lab in a week or so where we review the newest projects, trying to make this even easier for the surgeon. Now what I'm going to do is I'm going to pull the clamp part of the way out, but not all the way. Leave the red rubber in, because sometimes we get a little bit of interference from the clamp itself. Seen those, John. And let's check Jody again. This is the intrapulmonary vein here.
That white thing at the 12 o'clock position is called the sponge stick, and he essentially put we call it 4x4. So he's using it to pull the heart out of the way.
And this is bifurcation here. So what we're going to do now is, since we're in rhythm, we're going to try to pace the heart. We can also hold this right here. We can also pace the heart. No, I think we're in flutter now. Looks more like flutter, so we can't pace. Oh, is it? No, I think it's.
If anyone's got any questions,
Check on the atrial.
please feel free to
That's
speak
flutter.
up.
That's atrial flutter. And I wanted to show you the line we made. If I pull this over, come in a little bit, this is the line we made right here.
Oh, yeah. We see it well. Yeah. That close enough for you?
Now we'll put the clamp in one more time. We cleaned off the jaws. So sometimes you can get, sometimes you can get a little char on the jaw, and that'll prevent a good burn all the way through. So let's have a transfer. Okay, now we've cleaned off the jaw.
So what are you doing now, Randy?
And I'm going to put it in and do a couple more burns.
That's called
still
blood.
On the inferior vein soft. Just a little bit of something.
So you have to wipe the scope every now and again. You just got to take the scopes off and wipe them. Hopefully just a little bit of blood.
We're back in again. Want to make sure we get a good burn here. I thought Jody saw a little bit of signal there.
So you're still not
Just a
happy that it's
tiny
completely
bit.
isolated. So in that operating room, there's also a cardiopulmonary bypass machine. Doesn't need it very often. In fact, I'm not sure we've ever had to do it. But it's always set up that you can convert to formal open heart surgery should there be an issue. And there's a what I call
That's right.
perfusionist who runs the cardiopulmonary bypass machine is in the room. And the anesthesiologist, Dr. Roy Scheinbaum, actually he joined us from UT recently. He's a very experienced CV anesthesiologist. And the nursing teams are wonderful. That's for their benefit. If I don't say that, they can make my life miserable. The important people in my world are the nursing staff that you work with in the operating room.
So we've done a few more burns, Alan, just to
Okay.
see if we get a little bit flatter line. After this,
So after this, you're going to put the clip on the appendage? Hey,
we're
Randy.
going to do the clip. You ready? We'll do the clip right now. Hold on a second.
Okay.
How's that, Jody? Now we're testing the signal in the veins and in the other vein. All right, and the bifurcation. All right, good. We'll come back to that. Let's see, do you have time to watch the appendage being closed?
Yeah,
Can we do that now?
that's what we want to see. We're running a little bit behind.
All right. Hold this here. Let's have a sponge stick and suction. This is the appendage right here. You see
The
it hanging
funky looking
out
thing that
there.
looks like a sea anemone is the atrial appendage. He's going to grab it and lift it up.
Out there. Okay, now this, we have to measure what size clip we need. We're going to use an Atrial clip, also developed by AtrialCure Incorporated.
These come in all shapes and
I
sizes.
think-
Nobody actually knows what the atrial appendage is for.
50. So let's take this out. Let's have another port. We're going to move this port over because I need to put the clip in through this port. Yeah.
I suspect this is the first for Rice Business School showing open heart surgery in here. Well, it's interesting. A stroke is the most expensive thing that can happen in medicine. And there's a huge amount of investment in patients who have a stroke and reversing that because it's the single most cost-effective intervention. Strokes don't kill you by and large. They basically just maim you for the rest of your life. And so the societal costs of strokes are off the charts. Right now there's a huge amount of interest, and we're kind of heavily involved in this, about how do you deliver stroke care across the United States. So the contemporary way of treating a patient with a stroke is you got to get up into the head and pull that clot out. The problem is there's only about 800 people in the country who are qualified to do that. Now, if you happen to live in Houston, not a problem in the medical center. And where's Bill Klein? Because, Bill will tell you that the problem's in rural medicine, and rural is only a couple of hours from here. You just don't have access to this. I mean, there's a golden hour by which you got to get in there and remove that clot. And so we're very interested in being able to offer those services. Usually, if you see outside, there's Corindus, there's a robotic catheter, and we're actively working with them to try and use telemedicine to actually on-site in these peripheral hospitals remove clot from the head. That's once the stroke happens. What Randy's doing here is all about stroke prevention. And so essentially this is a big clip that he's going to apply. That's the clip that's in the jaw. That white thing is the clip that's in the jaws of the delivery system. And right now he's orienting it. He's going to grab the tip of that appendage and going to place this clip right across the base of it. And so the parts of this operation, number one, ablation to try and resynchronize the heart. And number two is stroke prevention. And this may be the most important part of this, because it doesn't seem like if you're at an atrial fibrillation, have a relatively slow heart rate, the downside of that, it's not great, but it's not near as bad as the risk of having a stroke associated with this.
Alan, before we started the procedure with the patient asleep, Dr. Scheinbaum looked at the appendage. It did not appear that there was any clot in the appendage. If there would be clot in the appendage, that would preclude this approach.
Yep.
So we always check that first.
So the way that,
I'm just carefully manipulating this around here.
and so the way that you look at that, actually, it was on the screen a little earlier, was with a Trans-Esophageal Echo. The atrium lies right in front of the esophagus, your swallowing tube. And so they pass a ultrasound. That's a Trans-Esophageal Echo. That's an echo probe that's put in the esophagus right behind the heart. And that allows Dr. Scheinbaum to look into the heart and make sure there are not any clots here.
I think I'm pretty much around it now.
Okay. So he's going to fire this, and then
now
as soon as you get that thing
now that
deployed,
I'm
Randy,
all
we're going to leave
around
you.
I'm going to close the clip. While we're looking at transesophageal echo, what do you think? Roy says it looks good. The appendage just disappeared. And that's what we want to hear. Sure, I don't have too much in there. Looks pretty good there. Looks pretty good. A little bit wide apart there.
He's just trying to make sure he's all the way across the base of this.
Hold that right there. Make sure I'm all the way to the tip here. That looks pretty good. It's still good, Roy? Yeah. Okay, so now we're going to deploy the clip. The atrial clip's now deployed. And we'll take the scope out and give you a little bit better view through the other hole.
So that's the clip, and the atrial appendage is now completely isolated. So Randy, let
Now,
me...
in addition to decreasing the chance of stroke dramatically, in some patients, the AFib originates somewhere around here.
Yep.
So we've also eliminated an AFib stroke focus by putting this clip on.
Okay, Randy, we're going to have to move along. Thank you very much indeed for showing this, and please give our thanks to the patient. We appreciate it very much. You going to introduce? Let me introduce Zoran. You going to introduce our next?